Hello, everybody. Welcome, welcome, welcome. Tonight, our guest is Dr. Sheenen Moa, kidney transplant surgeon at the Mayo Clinic in Jacksonville, Florida. Our topic for the evening is kidney transplants in pediatric kidney patients. Dr. Mao is the surgical director of kidney and living donor transplants at the Mayo Clinic in Florida. She completed her medical school at Harvard Medical School. She went on to complete general surgery residency, abdominal transplant surgery fellowship, and the clinical investigator training program at the Mayo Clinic in Rochester, Minnesota. Clinically, she is involved in all aspects of surgical transplant care for recipients of kidney, pancreas, and liver transplant, as well as living kidney donors. She has an active basic science and clinical research laboratory with special interest in applying regenerative medicine and machine perfusion to rehabilitate deceased donor organs, surgical post-transplant outcomes, and increasing access to transplantation. Please give a warm welcome to Dr. Sheenen Moa. How are you, Doc?
I'm doing great. Thank you so much for having me tonight.
Did I get everything halfway right in the introduction?
You sure did. It was fantastic. Thank you so much.
Please tell us a little bit about where you grew up, your educational background, and your employment history.
Sure. So I grew up in Iowa in a rural community. I actually grew up on a farm. I tell people my first operation was on a pig when I was 8 years old. I went on to undergraduate, majoring in biology and chemistry at Creighton University in Omaha, Nebraska, and subsequently did medical school at Harvard Medical School. From there, I had my first exposure to kidney transplant as a first year medical student and really became enamored with the impact that a kidney transplant can have on a patient's life, specifically someone who is going to dialysis, as many of you are, multiple times per week, gets a kidney and a new lease on life. And that's really when I decided that transplant in the field of transplant surgery was for me. I went on to do general surgery residency as well as a fellowship in abdominal transplant at Mayo Clinic Rochester. And following completion of that training, as well as some additional research training in expanding access to transplant, I ultimately started my career at Mayo Clinic in Jacksonville, where I've been for the last 4 years, doing all aspects of transplant. So I'm a active kidney, liver, and pancreas transplant surgeon. I also have a basic science research lab, and I'm involved in living kidney donation as well.
Excellent, excellent. Had the pleasure of being the moderator at your PKD Con 2022 talk on transplants in children.
Mhm.
And that is the topic we would like to discuss with you today. Let's initially talk about what a parent and child can expect from the kidney transplant process. And let's start with the importance of considering a transplant early on.
Absolutely. So, a very common misconception is that an individual would need to be on dialysis before they go on to a kidney transplant evaluation. In fact, that is not true. If your physician team identifies that you or your child is progressing towards kidney disease and has a reduced kidney function, transplant is a great option for you. You can become listed and possibly even transplanted before you ever would need to go on dialysis. That term is called a preemptive kidney transplant, and it's particularly common in our pediatric patients.
Okay. Talk to us a little bit about how a preemptive kidney transplant works. Is is that something where a live donor is always necessary?
So, not always, but often it's necessary to have a living donor. So, living donors can be anyone who donates a kidney to you or your family member. It can be a friend, a family member, sometimes a stranger would offer a kidney. The real benefit of a living kidney donor is that surgery can be scheduled at the convenience of both the donor and the recipient, and that can be done very quickly. There is a waiting time for deceased donor kidney transplants. That waiting time for our pediatric patients is generally speaking shorter as they are given priority access, particularly to younger donors, donors less than the age of 18, or young donors with expected excellent kidney function given their expected long term quality of life. If you are evaluated for transplant, and if your kidney disease progresses slowly enough that you make it to the top of the deceased donor waiting list, those transplants can also be done preemptively.
Okay. I've had other physicians on before that talked about preemptive kidney transplant. Is there a particular GFR, EGFR rating that you would recommend that someone start to think about preemptive kidney transplant, or is that something that you start to think about right after you're diagnosed?
Sure. Every center has a slightly different criteria for actively listing on a transplant list. And some centers will look also at the rate of decline of one's GFR, meaning that if you initially started with a GFR that was, say, normal and your GFR dropped to, say, 30% in a period of months, you may have more priority than someone who had that same decline over a period of years. At our particular program, we're happy to evaluate at a GFR of less than 30 to 40, but we typically do not list or recommend transplant until the GFR is less than 20. So, again, you could go through an evaluation, be assessed, have your living donor worked up, even if your GFR is a bit higher than that cutoff, but we wouldn't want to proceed to transplant until we get to that sort of GFR less than 20. For listing on a deceased donor list, the GFR does need to be less than 20, and that's the rationale where we use that as our cutoff at Mayo Clinic Jacksonville.
Okay. You've mentioned to us that an early referral for a pediatric kidney transplant is so very, very important. As a parent, when should a parent start to consider working toward a pediatric kidney transplant? Early
Excellent.
referral.
Excellent question. I would say when you're initially referred to a nephrologist and they begin to speak about a chronic nature of the kidney disease, that is a perfect time to begin asking about your opportunities for transplant. If the nephrologist feels that your child's kidney injury is acute and will likely fully recover, then it's time to give that kidney a chance and hold off. But if they start to discuss chronic kidney disease or progressive kidney disease, or for example, our patients with PKD, again, we know that the likelihood of that disease progressing is high, and that's where we want to start thinking about an early referral. You can never ask too soon your nephrologist about a transplant evaluation.
Okay. Let's talk for a minute about primary renal disease and limitations to the types of kidney disease a child can have that would affect their ability to obtain a transplant. Are there any limitations based on the type of kidney disease that a child would have that would prevent them from obtaining a transplant?
So, no, there are no limitations on the type of kidney disease. The very important factor, though, is if we know that the kidney disease is perhaps caused by a congenital abnormality, we need to correct those factors before we would go forward with a transplant. For example, if your child's kidney disease was caused by a bladder that was not functioning well, we need to have a good alternative or a new bladder created before we would go ahead with a transplant to ensure that that same process doesn't happen to the new kidney. Another common disease in children is called FSGS or focal segmental glomerular sclerosis. It does have a higher chance of recurrence in both children and adults, but that doesn't mean they're not a candidate for transplant. It just does mean we need to have that disease under control and have very close monitoring for your child after transplant. But there's no absolute contraindications of any disease or process to go to transplant.
Okay. I heard you mention during your talk with uh, PKD Con that PKD is a good condition to have if a parents wish to discuss transplant evaluation for their child. What makes PKD such a good condition, lending it to transplant for pediatric patients?
Absolutely. So, polycystic kidney disease or PKD is a congenital abnormality that affects the native kidneys. What's unique about it compared to other causes of kidney disease is it doesn't come back in the new kidney. The new kidney has different genes, different genetics, and so we don't have to worry about recurrent disease in patients with PKD. Some of the other causes of both pediatric and adult kidney disease can come back, and we worry a bit more about recurrence.
Okay. Let's talk for a minute about the considerations in the selection process for a transplant program for your child with PKD. What are the important considerations in selecting a transplant center for your child?
Mhm. So I think first and foremost, it's important that you identify a transplant center where you have support. The transplant process, both waiting for transplant, the actual transplant itself, and thereafter is going to be a life changing experience for you and your child. And so it's important that you identify a place where you can get to quickly if an organ becomes available. You identify a place where you either have family or friends that you can stay with or that has identified places where you can stay. For example, in our transplant program, we ask that you stay locally within the Jacksonville community for at least 21 days after transplant. We have opportunities in places where you can stay, such as the Transplant House, which is a bed and breakfast. We also have contracts with some of the local hotels and things like that to help our patients from out of town stay. Other things that are important is that you have a really good connection with your pediatric transplant team. So it's important that the hospital has pediatric nephrologists, surgeons specializing in pediatric transplant, child life support just to help support both your child that's ill and perhaps any other siblings that are going through a scary process. And then finally, it's important to look also at the outcomes of the pediatric transplant. The website www.srtr.org is a website run by an independent entity that allows comparison of transplant programs. So it's a double check to make sure that your program does a high number of transplants and does those transplants successfully. And every program doing transplants is listed on that website.
Okay, and just so our audience knows that that website is currently scrolling across the screen. And also, if you look at the original broadcast on Facebook, the website is in the comments. All kinds of interesting information is in there, including how you can contact Dr. Mao. So, check out the comments if you have an interest. Talk to us about what occurs during a transplant evaluation process for a pediatric kidney patient.
So during that transplant evaluation, the specific timeline may differ from center to center, but the general elements are the same. You and your child will meet with a number of different individuals, specifically pediatric transplant nephrologists or the medical team evaluating the kidney disease, a surgeon, someone who does the actual transplant operation. You'll meet with social workers who can help with supporting you and your family through some of the challenging financial, relocation, family support decisions. You'll meet with the nutrition team to talk about specific nutrition needs both prior to and after transplant. Another extremely important element is what we call child life, which can provide support to you and your family, and not only your child that may be undergoing transplant evaluation, but siblings to help them understand the process that they're going through. There will also be meetings with pharmacy to help with some of the new medications and perhaps also the medications that are needed prior to transplant. And sometimes there's also meetings with financial services as needed to help provide the support to get through transplant effectively. After all of those teams have met, oh, and one additional component I didn't mention was your nurse coordinator. This will be kind of your captain of the ship, the individual that helps to really move you through the evaluation process and serve as your point person after you're approved for transplantation. After you've gone through all of these processes, then that whole team will meet together in what's considered the selection committee. Everyone will discuss the individual risks that you or your child would bring to the table, and also any ways that we can overcome those risks and make a decision if transplant is in you and your child's best interest.
Okay. Are evaluations for pediatric candidates different than adult candidates?
They're very similar to the actual evaluation process is very similar to adult candidates, but I would say that the children are never small adults, and we really want to tailor the evaluation to be appropriate for children and make sure that we're not, you know, increasing the trauma or the healthcare concerns that obviously your child is facing going through having a chronic illness. We try to limit blood draws as much as possible. Any imaging, radiologic tests are limited as much as possible and are really explained to your child at a level that they can understand and at an age appropriate level.
Okay. How long does the process take for pediatric kidney patients, the evaluation process?
Every transplant program's a little different in terms of the timeline. Our program tends to be somewhere around 3 to 5 days of evaluation process, but every program's a little different and every child is a little different. If there are multiple health conditions in addition to kidney disease that may play a role or impact the transplant process and the recovery, the evaluation may be longer. And in children that have disease limited to the kidney, that evaluation is probably closer to that 2 to 3 day period.
Okay. Talk to us a little bit about the role of a pediatric transplant coordinator. What does that person, he or she, do?
Your transplant coordinator is really the captain of the ship. They're that primary point of contact for you and in helping to understand every element of the transplant process. They're also the individual that typically at most centers is on top of getting you and your family to the selection committee to be discussed. They know if something has come up that may limit your access to transplant, or if something has come up, new in your life. For example, maybe your child has been hospitalized. They're going to be the person that you would call to say, my child has a new illness, let me report this to you so that the transplant team can be aware.
Okay. Talk to us about the role of the pediatric transplant surgeon. What concerns may that person have that are unique to child patients?
Absolutely. So, first and foremost, probably the most obvious unique consideration is the size of the child. And this is particularly important when we're considering children under 30 pounds. The reason for that is really making sure that we have enough space to put in a new kidney. Particularly if we're talking about an adult kidney into a younger child, we want to think about space considerations. We also want to think about the blood vessels and the size of those blood vessels. Typically, in a teen or an adult, we would do that kidney transplant down in the blood vessels that feed the leg, and that new kidney would actually live down in the pelvis, down by the hip bone. In children, in contrast, particularly smaller children, there may not be enough room, and those blood vessels to the legs may be too small to support a kidney. And we actually need to use the larger blood vessels that run along the spine or the aorta and the inferior vena cava to place that kidney transplant. And it sits much higher up in the child's belly. Also, if your child has other medical conditions or has had other prior surgeries, it's important for the surgeon to evaluate those concerns and confirm that any other prior conditions wouldn't affect the ability to safely receive a kidney transplant.
Okay. Talk to us a little bit about the role of a pediatric transplant nutritionist.
So, the pediatric transplant nutrition is extremely important to help with planning both pre and post transplant and to help with your child's nutritional status. Oftentimes, being on dialysis or even a renal diet can be very limiting for a child. And as we all know as parents, children are not always the best eaters, so they can help with maintaining your child's nutritional status and optimizing their nutrition and health prior to transplant. After transplant, I always say that the primary goal is to get individuals back to as close to a normal life as possible. There are a few limitations on foods that can be eaten. Primarily, those are related to the medications and may include limitation on such foods as pomegranate and grapefruit, because it does interact with one of the medications that both children and adults potentially would take after transplant. So, it's helping to understand some of those limitations. The other major limitation after transplant is that we ask that you avoid foods that have a high risk of foodborne illness, and that would be primarily raw and undercooked meats, things like tartare and sushi. And that's just mainly to avoid an infection risk because your child or the recipient would be immunocompromised and at a higher risk of infections.
Okay. Speak to us a little bit about what a transplant social worker does for pediatric kidney transplant patients and their folks.
Absolutely. So, a transplant social worker's role is to primarily um, have conversations about how to best support you and your family, both going through the transplant process as well as after transplant. If you may need to relocate because your approved transplant center is out of a geographic range from your home, They can help with ensuring that the medications are affordable and that you have the insurance support to afford the lifetime supply of medications. They also can be extremely helpful with ensuring support for your child and for your siblings, because again, siblings are in a very unique position in pediatric transplants, seeing their loved one going through this illness and maybe not fully understanding or comprehending. And there's a lot of big feelings going on in the mind and the depending on the developmental age of siblings as well. So they're there to help support really your whole family as well as parents. And many times parents are the living donor for a younger child. And so again, that can be scary for the whole family to go through, and a social worker can provide that support element as well.
Okay. Talk to us about what a transplant pharmacist does for the pediatric kidney patient.
So, our transplant pharmacists are primarily responsible for evaluating the medications your child is on before transplant, ensuring that there's no medication interactions then, but more importantly, after transplant, helping to balance the immunosuppression, confirming that the patient is not having any side effects. Generally, immunosuppression is very well tolerated. However, it's important to ensure that there are no side effects that may limit a patient taking that medication as prescribed or that may lead to higher levels than expected, because then there can be side effects and complications. Transplant pharmacists, particularly in the pediatric world, can also be helpful if a child is not yet able to swallow pills, for example, with managing liquid or dissolving underneath the tongue medications. And then as the child grows, and helping to transition those medications to a formula that they may be more comfortable with. So a young child may want liquid formulary, but by the time that child has reached the teen years, it's probably more convenient for them to take their medication in a pill form, and a pharmacist can help with making those transitions.
Okay. You mentioned child life to us earlier. What is child life and what is their role in the transplant process for pediatric kidney patients? And just so our audience knows, the link to the child life is in the comments to the original broadcast on Facebook.
Fantastic. So, Child Life is a group of individuals at a pediatric hospital who really specialize in helping children to understand the various elements of medical care. So, it can be even things as simple as supporting your child through a blood draw or an IV, to some of the more complex issues of perhaps recovering from transplant and their first experience with postoperative pain. Can also help with siblings that are having challenges with some of these big and scary incidences in their life. Child life can also be very helpful with helping in that transition from perhaps parents having a more active role in medication administration to someone who is growing up with a transplant and taking on some of the roles of managing their own medications and ensuring proper compliance, making suggestions about how to remember to take your daily medications, things along those lines. So they're critical to the entire process for our patient from transplant to many years after transplant.
Talk to us about the goals of laboratory studies in pediatric kidney transplant patients. What are the ins and outs that go along with that?
So, laboratory studies are very important regardless of the age of the transplant recipient, and they're truly our first marker that something might be going wrong. I'm often asked by recipients or parents, what are my first signs that my kidney is rejecting or that there's a problem? The real answer is 95 to 99% of the time, when we first notice a problem, it should be before you have a symptom. If we see early rejection, we may see it in a slight bump in the creatinine level, which would be something that we wouldn't see. Um, you wouldn't feel anything as a kidney transplant recipient. So I think it's extremely important that we get regular laboratory studies at our center during the first few weeks after transplant. That's quite regular. For the first week, it's daily or even more frequently. It backs down to a few times a week. And by about a month out from transplant, it's about once a week that you're getting laboratory studies. And that may even taper out further as we go forward. The other piece that's really critical to monitor is the levels of the immunosuppressant medications. Those levels can change based on how your body interacts with those medications. Also particularly important in children is as children grow and gain weight, those levels may need to go up because they have more body mass. And so we need to monitor those levels closely to make sure that they're not too high and possibly causing complications, or too low and leading to a risk of rejection of the kidney transplant.
Please discuss the importance of imaging tests with
Mhm.
pediatric kidney transplant patients.
So, imaging tests, again, are variable and specific to the individual patient, but it's important to make sure that we understand as best we can before the surgery your child's unique anatomy. Specifically, we want to make sure that there's a safe and effective place to implant the kidney, as well as the urine tube or the ureter that connects it to the bladder. We want to understand better if there are any abnormalities that perhaps your child was born with or that came about after a prior surgery. And then also in our PKD patients, for example, we need to ensure that there's enough space. Sometimes our polycystic kidney patients have extremely large kidneys for their small body frame, and there simply isn't enough room to put another kidney in. And an imaging test, such as an ultrasound, is a very safe way for us to understand how much space is in there and if we need to plan ahead to possibly remove one of the native kidneys or the kidney that your child was born with to have space for a new transplant.
Okay, let's talk about the next step, the listing for a transplant and the selection committee. Can you tell us what is it that a selection committee does?
So, a selection committee is made up of all of the individuals that you've met with during your journey through the transplant evaluation process. So, each of the individual people we spoke about before, the nephrologist, the surgeon, the nutrition team, the pharmacy, social work, everyone meets together. Classically, this was all done in one big room, but now I think we've all become Zoom experts. So, typically, we meet via Zoom and we discuss each individual case that's been presented over the past since the last meeting, which is typically monthly or weekly at most centers. We discuss any individual concerns and then make a recommendation that the patient either be listed for transplant, not listed for transplant, and the rationale or reason why. And then in the middle, there are sometimes candidates that we think are excellent candidates, but perhaps need additional testing before they're ready to ultimately receive a transplant. So your options after the committee, and this will be communicated by the nurse coordinator, would be approved and ready for transplant, wait list or essentially additional evaluation needed, or decline for transplant. And every program will tell you specifically why a decline was made if you were declined. And to follow that up further, I always encourage people, if you happen to go through an evaluation at one center, you or your child, and a decline is made, that doesn't mean that decision is the same at every program. So if you have the ability to travel to a different center, it is reasonable and very much anticipated that you may go to a second evaluation at another program. At our center, we are more than happy to review records from another program that you may have been evaluated at to try to limit some of that additional testing.
Okay, so multiple listing is something that you encourage?
Absolutely. I think, especially if you or your child doesn't have an opportunity for a living donor transplant, the more that you can be evaluated and listed, the better. If you have opportunities at transplant programs that are geographically somewhat separate from another, that may also help your chances. So, deceased donor organs are offered out based on the geographic proximity to the donors or to the hospital, meaning a 250-mile radius around that hospital or a circle drawn around that hospital is where you first and foremost see offers from. And so, if you have the opportunity to be listed at centers that have circles that are different from one another, you would be potentially more likely to receive a deceased donor transplant more quickly.
Okay, let's talk about the role that UNOS plays, the United Network of Organ Sharing Listing,
Mhm.
and why it's important to be on their list.
Absolutely. So UNOS is the governing board. It exists as a separate entity apart from any transplant program. And when a deceased donor becomes available, the what we call the Organ Procurement Association, or OPO, goes out and evaluates that donor, provides information to the UNOS network, and then UNOS runs a list of patients in order of priority to receive that organ. That order of priority is determined first and foremost by your blood type. Next factors include, and since we're specifically talking about pediatric transplants, in our younger donors and our donors that have what is perceived based on their health status as having the longest quality of life, pediatric transplant recipients will get priority for those organs. And then it's based on time on the waiting list. So individuals that have been on the list longer have more priority for an organ transplant. It does not mean you have to be on dialysis. It's the period of time that you've been on the waiting list or the period of time that you've been on dialysis, whichever comes first.
Okay. You talked a little bit about the priority that children receive. It's my understanding that if a child is looking for a deceased donor, that their priority is with potential donors that are under 35 years of age. Is that a correct statement?
Yes, that is the correct statement. The priority is offered to donors less than age 35. And the rationale for that is we want to match recipients to organs that we think will give them the longest quality of life. We know that younger organs tend to last longer, and we want to ensure that younger individuals have as much potential for a lifelong or as long as possible transplant.
Okay. Um, the reason that we want to match organs with our pediatric patients is that they last longer. What happens if I have a teenager who at the time they are listed, say they're 15, 16 years old, but by the time they're 18 or so, they don't make the transplant? What happens if they become 19, 20 to the priority?
Great question. A child that has been listed before the age of 18 or at the age of 18 retains that priority until they are transplanted. So you don't have to worry about your child aging out of the transplant list and all of a sudden losing a priority when they turn 19. They'll continue to maintain that.
Okay. Um, we talked a little bit about the evaluation of potential living donors as leading to a quicker transplant for your child. So if my child happens to show up with a matching donor, so to speak, how much quicker are we talking about a possible transplant for that child patient?
Absolutely. That's a fantastic question and something that's definitely near and dear to my heart. So, living donors, individuals that offer kidneys on behalf of another individual, are scheduled as soon as possible and as soon as compatible for the donor and the recipient team, meaning that as soon as we get the recipient child through the evaluation and the potential donor through the evaluation, we will schedule that transplant. There doesn't need to be any sort of a waiting period of time. As soon as works for both individuals and works for the transplant team, they'll be scheduling. At our center, we can typically schedule within a month. Every program's a little bit different. That means there's no waiting time. That also means that instead of waiting for a call or, potentially being asked to drop everything and come to a transplant program at 2 in the morning on a random Tuesday, you're going to have a scheduled date and a time in which to show up for the surgery. That also, just as a preamble, if the donor, for example, needs to schedule at a certain time, we can also work with that. So sometimes I've had donors that, for example, are school teachers and really prefer to donate during the summer months when they're off of work. That's something that we can also accommodate within the living donor program. A final piece related to living donation also is that if for some reason a donor is thought to be an excellent donor but can't directly match their intended recipient, whether that be a child or an adult, it is possible that they can donate through what we call the paired exchange, They would donate a kidney to someone they were a good match for, and someone else would donate back to your child as the recipient of the kidney.
Okay. Where you are, the Mayo Clinic in Jacksonville, do they recognize the voucher program?
We do. So that's an excellent question. So the voucher program is an opportunity through the National Kidney Registry. So essentially an individual would donate a kidney to someone in need. They would name that individual, and if that individual is not yet ready to receive a transplant, they would receive a voucher that at any point going forward, when they are ready to receive a kidney, they would get a kidney back from the kidney registry. And that's something that can be done at any point. Um, a recent really exciting story, I had a grandmother who wanted to donate on behalf of their grandson that they knew was was unfortunately going to need a transplant at some point in their life. And the grandmother really wanted to donate while they were still in good health and felt that the kidney could be of asset and of benefit to someone. So they donated. And then their grandson had a voucher that could be used at any point in his life going forward.
Okay. Let's talk a little bit about numbers so our audience understands. It's my understanding that pediatric kidney transplants, 966 peds are added every year between the ages of 11 to 17. And pediatric kidney donors, the most recent that I could find was 2018, 756 pediatric kidney transplant. Do those numbers sound fairly accurate to you?
They do. They sound pretty accurate. Yep.
All right. Let's talk a little bit about the donor selection process in pediatric kidney patients. What is HLA matching?
Okay. So HLA matching is essentially looking at what antibodies your kidney would offer. So that would be, or what your body essentially offers. That would include things like, have you ever been exposed to the blood of another individual, for example, through a prior transplant, through a blood transfusion, and would you react to other people in the population? It's important that we match as closely as possible. And there is some initiatives now, including what's called the Kidney for Life initiative, where we're truly trying to really match kidneys as best possible to the recipients. Through the National Kidney Registry, the Parent Exchange program that we spoke of just a few minutes ago, a cheek swab is used. So, not even a blood test, a simple swab of the inner lining of the cheek is used to detect the presence of antibodies in the specific eplets that your child would match to try to find really the best kidney possible for them and to find a very close match that can hopefully last just as long as possible. Our medications for immunosuppression continue to improve, but we do know that the closer the matched kidney, the better in terms of avoiding rejection episodes that can lead to loss of transplant later on.
Okay. As I understand it, some of the benefits of HLA matching, epilep matching, the smaller part of antigens, less rejection, potentials for lower immunosuppression medication, and improved longer term options. Is that something that you would agree with?
Absolutely. I definitely would agree with that. The better we can match, the better opportunities we have for long term allograft function and preventing rejection. And certain programs even have opportunities with the best matched kidneys to reduce the immunosuppression even more than what standard levels are to avoid any long term effects of immunosuppression on you or your child's body.
Let's talk for a minute about what a parent can expect from a transplant organization itself. Talk about the highly specialized team of pediatric anesthesiologists, pediatric nurses, pediatric transplant surgeons.
Absolutely. So I would expect as a parent with a child going through kidney transplant that you would have access to a very high quality team whose priority is your child and your child alone at the time of the transplant. So the nursing staff is going to safely bring your child to the operating room. In some cases, parents are allowed to come back to the operating room as well until their child falls to sleep. The anesthesia team is dedicated to your child and your child only, making sure that they're safe and monitored throughout the process. The kidney transplant surgical team is going to be the team that's actually doing the transplant. It typically will include a pediatric transplant surgeon, an assistant, which may be a resident, a fellow, a physician assistant. We always have at least one person that's with us helping to conduct the transplant in a safe fashion. And then after the surgery, that team is going to communicate with you how the transplant went, let you know of any concerns that they may have or any things that we need to watch out for in the coming days. And then they're going to continue to see you in conjunction with the nephrologist going forward during your hospital stay and in your post transplant recovery.
Talk to us a little bit about parents actually being in the operating room at the time of transplant, pros and cons.
So it depends on the center. At our center, we do typically for younger children allow the parent to come back if the parent wishes to be with their child as they're falling off to sleep. During the actual surgery, you're escorted out of the room. Not all centers offer that opportunity, and it's really up to the parent. Medications that are given, the anesthesia that's given at the time of transplant has an amnestic property, meaning specifically most patients don't remember any element of the operating room at all. So it's probably more concerning for parents and friends and family members that are having to say goodbye to their child. But that amnestic property, when I ask my patients, what do you remember? Occasionally they'll remember counting down. Oftentimes an anesthesiologist, before you fall off to sleep, will have you count from 100. Most patients don't make it beyond 95. A few patients remember that, but most actually don't remember anything. I'm usually in the room as the patient's coming in. Probably 99% of the time, they say, "I didn't even see you, doc." And I'm always in the room when they come in the room.
Okay. Um, how long does a pediatric transplant surgery take? What kind of time are the parents going to be waiting around for this to
That's a
take place?
great question. It is somewhat individualized based on the size of the child as well as the other comorbid conditions and risk factors. Typically, I would say that somewhere between 2 to 3 to up to 4 to 6 hours, depending on the age of the child. Typically, teenagers are a little bit easier because we have a little bit more space to work with than younger children. And also, it depends on any prior transplants or prior surgeries that could increase that technical risk. Our team, though, is there to keep you informed. So, in our program, our nursing staff will give you a call or send a message when the transplant actually starts. Because, again, when the patient leaves the care of their family members, the first portion, up to an hour, is actually our anesthesia team helping the child off to sleep, making sure the monitoring devices are placed. So our nursing staff will give you a call when we start. Typically, once the new kidney is sewn in with blood supply, and then a call as we're finishing the bladder connection and finishing the operation. And then I will come out and talk to you and your family after the transplant. If things are taking longer, we typically have our nursing staff call every 1 to 2 hours just to give an update so everyone knows what's happening and to keep you informed.
Okay. What is the average stay in the hospital, including an ICU,
Mhm.
after a pediatric transplant?
So the use of an ICU really depends on the transplant program as well as the age of the child. Some transplant centers routinely send all patients to ICU. Other transplant centers use the ICU a bit more sparingly. Average stay in the hospital typically ranges from somewhere around 4 to 7 days. It can potentially be longer, depending again on the individual transplant program's requirements, as well as any challenges the individual child has. And that's definitely a fantastic question that you can ask your team. both pre-transplant, but also the first 1 to 2 days after transplant when we see how things are going. That's a good time that we can give an estimate for how long you can expect your child to be in the hospital.
Okay. Let's talk a little bit about the difference between kidneys that work right away and sleepy kidneys, kidneys with delayed graft function, or what you've referred to as DGF.
Excellent question. So, l- we would love if every transplant worked right away. Realistically, particularly deceased donor transplants, the events that have led to the donors passing away can potentially mean that the kidney's sleepy or has delayed function. That doesn't mean that it's not going to ever function. It just means that in the short term, it's not functioning as well. It means that the child may need to continue dialysis if they're on dialysis, or may continue to have kidney disease for a period of time. That time frame in children, because of the high quality deceased donor organ, is typically shorter. However, that could last up to several days to even a few weeks. Living donor transplants, we expect to work on the operating room table. Up to 98 to 99% of living donor transplants actually make urine on the operating room table. So it's a bit less common in those cases, but it can happen even in a living donor transplant. Your transplant team is going to support you and your child through that process. If dialysis is needed, it's okay. It doesn't hurt the new kidney, and it just allows that kidney the opportunity to wake up and start working. And we haven't seen significant difference in long-term function in kidneys that have had a period where they needed extra dialysis going forward.
Okay. Let's talk a little bit about some other post transplant complications, surgical and possible medical complications.
Sure. From a surgical perspective, early on, some of the big things that we would worry about, particularly in smaller kidneys, particularly kidneys coming from very young donors, would be problems with the blood vessels. Those blood vessel connections are very small. They can be under a centimeter, or about that size, or even smaller. Those could scar or leak, and that can require additional surgery for us to correct, or potentially a trip to the radiologist where they use things like stents, if you've heard of heart stents, to try to open up those connections. Other things that can happen would be problems with the wound, meaning a formation of a hernia or a bulge at the site of the kidney transplant, or an infection at the site of the kidney transplant. Thankfully, in our pediatric patients, that's relatively rare, but it does happen, and your team should be there to support you through it. On the medical side of things, some of the things we worry about would be an early rejection episode. Thankfully, that's extremely rare, but we would be monitoring laboratory studies and, if needed, increasing medications in those circumstances. There are also some diseases that can potentially recur early, the most common being FSGS, focal segmental glomerular sclerosis, in the pediatric population. And we would need to monitor for disease recurrence and make sure that there isn't any additional treatment that would be needed to prevent the native kidney disease from affecting your kidney. And then finally, for some of our complex congenital patients, this may be some of the first time that an individual is utilizing a newly created bladder, for example, and we would want to make sure that that is anatomically functioning as anticipated, and that we wouldn't need the support of our pediatric urologist to correct any challenges there either.
Okay. Let's talk about post transplant discharge care. We don't just give up on the patient after transplant and send him home, right? What
Absolutely.
happens with post transplant discharge care?
Absolutely. So once you're discharged from the hospital, the discharge process is definitely not over yet. We are committed to your child for the rest of essentially their childhood. And in most programs, that would transition to adult related care as well, unless the child were to be moving away. You're really our patient for life. Right after transplant, we are going to be seeing you very frequently, several times per week, with laboratory studies and clinic visits. At our program, we typically ask that you're in the Jacksonville area for at least 3 weeks after transplant. Sometimes that's extended if there are post transplant complications. And then we work with your local nephrologist if you're from outside of our community to make sure that we're monitoring your kidney function, your immunosuppression levels. Then we like to see you back at 4 months and every year thereafter. Particularly unique to the pediatric population is that children grow up, thankfully, and we need to support them through all those transitions in their life. And a big transition really happens, as a child is becoming into their teen years, and then ultimately potentially going off to college or moving away. And again, we want to be part of those decisions and helping your child to continue with their growth and development, taking ownership of their new medications. And then if they do perhaps move out of the area for college and things like that, is connecting them with a nephrologist that can continue to support them through that journey of life as well.
We have a question from one of our big supporters, Bobby Reed.
Absolutely.
Bobby is asking about biopsies for pediatric kidney patients because in some adult programs they do biopsies. Do they do biopsies at Mayo for pediatric kidney patients or elsewhere, as far as you know?
So that's an excellent question. It's truly center specific. At our center, as you mentioned, Ms. Reed, we do a protocol biopsy at 4 months and 1 year in our adult patients. In our pediatric patients, we are somewhat less likely to do those biopsies purely on protocol, but biopsies absolutely can be done in children if there's an expressed concern. And likely there are centers that are offering or that are performing biopsies more frequently in children as well. Biopsy is a very safe procedure for both adults and children, but obviously there are some risks associated with doing so as well.
Okay. Let's talk a little bit about the immediate post-transplant surgical restrictions. What kind of restrictions do pediatric kidney patients have immediately after transplant?
Excellent question. So, right away after transplant, there are a few things that we ask that you avoid. For the first 2 weeks, we say no swimming or tub bathing, things that would immerse the wound so that we ensure that that heals up to the best of its potential. And then for the first 6 to 8 weeks after transplant, we recommend no heavy lifting, so anything greater than 10 to 15 pounds. That includes pushing and pulling motions. And that's again to help prevent formation of a hernia. Early after transplant, most programs encourage avoidance of heavy duty contact sports as well as the child continues to heal. But that's really a program specific decision and something to speak with your pediatric transplant surgeon about when they would feel comfortable with your child returning to activities. Ultimately, though, as your surgeon, my goal is to get your child back to doing everything that they want to do. And recipients of kidney transplants have gone on to be marathon runners and skiers, football players, and all sorts of different professions in between. And so, my goal is to get them back to doing everything they want to do as quickly and safely as possible.
Okay. Are there long-term post-transplant restrictions for pediatric kidney patients, particularly things that you would tell parents about?
So, long term care, follow up care is extremely important. So, we want to make sure that children, especially as they're going through transitions in their life, continue to take their medications regularly. Some of the medications do affect your reproductive potential in terms of meaning there is risk of birth defects and complications. So, as children transition to the teen years, it's really important to have conversations with them about the importance of utilizing two forms of birth control. Avoiding smoking is another important fact, particularly as our children transition into teen years and face a lot of those pressures, is knowing that smoking can have a high impact on the kidney transplant as well. And ask that although refraining from smoking is important for everyone, it's particularly important in a transplant recipient. Another area that here in Florida we talk about a lot is sun exposure. So, immunosuppression does increase your risk of certain skin cancers. So, it's important to always wear sunscreen when you're out in the sun and get regular skin exam. Children in particular have many, many years of exposure to the sun. And we here in Florida love our sunshine, but it's important to take protection as well.
Okay. What is the kidney function, the expected eGFR after approximately 1 year for a pediatric kidney transplant patient?
So that's a great question. It's hard to give an exact number, but what we would be expecting is that your child has near normal function with an individual with one kidney. In terms of giving a specific creatinine or a specific GFR, it's a little bit challenging to give exact numbers, but we would expect that your child would not have any dietary restrictions, fluid restrictions, that other than the transplant related dietary restrictions, certainly, but no nephrology or dialysis related restrictions, and that they would be living essentially a normal life.
Okay, let's talk about uh, protecting the transplant child's health after transplant. What are the kinds of things that are done
Mhm.
to protect the child?
So, again, we like routine and annual post transplant care. We want to make sure that your child's getting all of their recommended immunizations to protect them against any possible infections that may come up. We want to make sure that we're picking up on any problems that may be slowing their growth or the development, and any other complications or side effects from the medication. But ultimately, we hope that kidney transplant patients grow up and live a normal childhood life and have the risks and the challenges that all kids have. There may be a broken bone on the playground here and there and things like that, but really the goal is to give your child as close to a normal childhood as possible.
Okay. Um, are we looking at things like we see in adults? Daily medications, regular lab studies, yearly checks with your transplant team?
Great question. So, yes, daily medications are going to be part of the routine. Typically, it's a twice daily medication. Occasionally, there are regimens that are one time per day, but most regimens are twice daily regimens. And that, similar to adult patients, we're asking that those medications be taken at the same time. Now, what is nice is typically they are 12 hours apart. So medications could be taken, for example, before school and after school so that you're not requiring a dose during the middle part of the day, which can be very challenging for some of our patients. Also, there will be regular laboratory work. Early on, that's typically weekly. Occasionally, we can space that out. And again, we do our best with our pediatric patients to work around school and other obligations in terms of the scheduling of those laboratory studies. And then we do like to typically see you back at least every year to make sure that you're continuing to progress as we expect and to ward off any potential complications that are brewing on the horizon.
Okay. A little bit of a controversial question, doctor. My experience with pediatric kidney transplants, at least what I've read, is that it's important to update your vaccines. Can you speak to that a little bit?
Absolutely. And I would agree with that all childhood vaccination should really be continued on schedule for your child. Your child with a kidney transplant is immunosuppressed, is at a higher risk of contracting infections. So our program recommends that everyone continue to get their pediatric routine vaccinations. That would also include an annual flu shot. And in our COVID climate, recommendations for ongoing vaccination as in accordance with the CDC for COVID vaccination going forward.
Okay. I have a note from your discussion at PKD Con that the 5 year post transplant survival rate for pediatric kidney patients is approximately 98.4%, which is really good. Can you
Absolutely.
talk to us a little bit about that?
Absolutely. So we are very proud. The national 5 year survival rate is greater than 98%. In part, that is due to the high quality kidneys that are offered to our pediatric recipients. That's also due to the intense care that's provided by the entire team as well as the family members. Everyone's really a part of the team to provide care. I think the final factor is that the recurrence of disease is generally less in pediatric recipients when we compare to adult recipients. Many of the disease processes and the most common adult related disease processes are conditions such as diabetes and hypertension, which can recur relatively quickly. those conditions are less likely to affect our pediatric patients, and we're able to enjoy excellent post transplant survival with the support of the entire transplant team, but more importantly, the patient and their family.
Okay. We're in the home stretch here, Doc, I promise. Talk to us a little bit. Do you have any concluding remarks concerning our discussion today? Is there anything that you would like to say that you think is important that maybe we didn't cover, or that you want to remind parents and patients about?
What I would say to patients and parents is sort of similar to what we spoke about at the start of our talk. We, as a transplant program, say it's never too early to see you. We enjoy early referrals and the opportunity to list you just as soon as possible. Living donors are truly the heroes of the process, and never sell oneself short on a living donor. So if you or your child is going through a kidney transplant, don't be afraid to use your networks. Use your social media, Facebook, Twitter, Snapchat. Reach out, and you would be surprised at how many people want to donate a kidney, and particularly a kidney to a young person. I've had total strangers come forward and want to donate a kidney before. So reach out to your networks. And in the post transplant period, know that your team is there to support you. We're available for questions, both your immediate team, your coordinator as a resource to reach out to and get answers for any questions or concerns. And know that we're here, and we're a part of your life for the foreseeable future, truly the life of your child.
Thank you, Doctor. I really appreciate you coming out tonight and raising awareness and helping to educate us about pediatric kidney transplants. Wow, what a great job. A very interesting discussion. I'm going to let you go. I want to talk to the audience about upcoming broadcasts, but I did want to thank you again for taking time. And just so our audience knows, Doctor and I have a tentative agreement that she's going to come back and talk about regenerative medicine with us. So should be more interesting discussion coming up. So again, Doc, what a great job. Thank you so much for coming and speaking with us.
Absolutely. It was a pleasure to speak with everyone today. And I hope that you enjoyed the talk, and that we could impart and share a few pieces. And I do hope to see you and your family soon in a transplant program near you. Take care and have a wonderful night.
Take care, Doctor. Thank you again so very, very much. All right, everybody. What a great show. Wow. Great talk tonight. Let's talk a little bit about upcoming broadcasts. On the 14th of October, Dr. Christian Hanna is coming to speak to us about pediatric kidney patients. He's likewise from the Mayo Clinic, and PKD issues in children. Friend of the show, on the 21st of October, Risa Simon is back with us again. She has a new application for kidney patients that she wants to talk to us about. That should be interesting. On the 28th of October, Lainey Esquivel is going to be with us. By the way, Lainey had a very interesting post, something she wrote this week. You might want to check that out. She is a member of the PKD Champions Advocacy Group. We're going to talk about the PKD champs on the 28th of October. Allie Dawson, kidney patient, is going to come talk to us about her kidney story and her kidney experiences on the 4th of November. On the 11th of November, we're going to talk to our good friend, Rachel Rusma. Rachel was the wife of a kidney cancer patient. She's going to talk to us about some of the ins and outs of being a caretaker for kidney cancer patients. On the 18th of November, and this is extra special, so I want you to circle this one on your calendar. Tentatively, depending on her health, our friend Teresa Diggs is going to come talk to us. Teresa is a heart transplant patient. She's a kidney transplant patient. She's a mom, very, very active on social media. A lot to discuss there from my good friend Teresa. On the 2nd of December, Dr. Stenke's going to come and talk to us about his expertise. On the 9th of December, Christian McCall is going to come and speak with us, kidney advocate. And to end up the year on the 16th of December, the great Sharon Simpson Rouse is going to come talk to us. Kidney patient, kidney advocate, has her own not-for-profit group. So lots of interesting things coming up, and I'm lining up interesting things for discussion after the first of the year. So, watch this space and stay tuned. And I will talk to you guys all of a sudden. So I will see you next week. Don't forget, please share the broadcast. Check out my good friend Kent Bressler's Kidney Solutions. There's the information there. You need help getting a kidney transplant at no charge. The good folks at Kidney Solutions will help you. I do have a YouTube channel you can subscribe to. The link is running across the broadcast now. So, okay. Thank you very, very much for watching. We will be in touch, my friends. So you have a good evening.